All right. So this is going to be the structure of this. I'm going to cover spinal cord tracts, spinal cord lesions, cranial nerve falsies, and brainstem lesions. And Eman Chaudhri is going to cover cerebrum and blood supply of the brain. So the first hour is going to be spinal cord and brainstem, right? How we're going to do this is that I'm going to read the question, then I'm going to wait like 10 seconds for you guys to type in the chat, or if you want to answer, you can answer as well. Unmute your mic. Otherwise, we're just going to sort of run through the questions. After the questions, there's a small explanation for each question. And so you get to, revise concepts and stuff. All right. So a 52-year-old male with a history of gastric cancer that was treated with subtotal gastrectomy dies in a motor vehicle accident. At autopsy, examination of the spinal cord shows unilateral atrophy of neurons in the area indicated by the arrow here. Neurologic examination of this patient when he was still alive would most likely have shown which of the following findings? D, okay. All right. So let's go through them one by one. A says decreased pain sensation in the contralateral area. That's not right because that's mediated by the spinothalamic tract. This is showing you the dorsal column, specifically the medial part of the dorsal column. Decreased temperature sensation in the ipsilateral arm. Again, that would be spinothalamic. Decreased vibratory center in the ipsilateral arm. That would be correct. That's what the dorsal column does, but that would correspond to fibers in the fasciculus cuneatus here, which is more laterally. This is labeling the fasciculus gracilis, which means the correct answer is D, because the lamination of fibers from the dorsal column pathway means that the fibers from the lower limb are medially arranged, and the fibers coming from the upper limb, carrying sensation from the upper limb, are laterally located. This is in contrast to the spinothalamic tract, which crosses at the level. And so fibers for the upper limb are located medially, and fibers from the lower limb are located laterally in the spinothalamic tract. Okay, so let's move on. This is a small summary for you guys. These are the main three tracts you should be aware of. The dorsal column pathway carries sensations of two-touch discrimination, vibration, and conscious proprioception. The first order neurons, their cell bodies, reside in the dorsal root ganglion. They don't synapse or decassate when they enter the spinal cord. They ascend ipsilaterally. And they form the fasciculus cuneatus laterally and the fasciculus gracilis medially. Then they go and synapse in the medulla with second order neurons. These are called the nucleus gracilis and nucleus cuneatus. From the medulla, they decassate to the opposite side. And this decassation is called the medial lemniscus. And then they ascend up the brainstem and go to the thalamus into the as the medial lemniscus, where they synapse as the ventroposterior lateral nucleus of the thalamus, right? The spinothalamic tract carries pain, temperature, sensations. Its fibers decassate immediately. That's all you need to know about it. And they ascend contralaterally. So lesion in the spinothalamic tract would manifest contralaterally. The lateral corticospinal tract is the upper motor neuron supply. Its first order neurons come from the precentral gyrus, from the cerebral cortex. They descend through the medulla. At the level of the medulla, they decassate. This is called the pyramidal decassation. And then the synapse at lower motor neurons in the anterior horn. The lower motor neuron leaves the spinal cord and innervates muscles, right? These are the main three tracts you should know. Now, this is another question about spinal cord tracts. A 73-year-old woman comes to the physician for a follow-up. 3 weeks ago, she was diagnosed with herpes zoster in the T10 dermatome, the right T10 dermatome, which corresponds to the umbilicus. The rash has since resolved, but she now reports continuous burning and stabbing sensation in the affected area. During neurological exam, the physician tests the patient pain and temperature sensation in the right lower abdomen. Which of the following labeled parts of the upper thoracic spinal cord is responsible for transmitting this information? Just to orient you, this is right, this is left. This is anterior, and this is posterior. So this is anterior, and this is dorsal. Okay, so should I go through the options, or if someone type in the chat, what do you guys think? C, okay. All right, okay. So A corresponds to the dorsal column, H corresponds to the dorsal column. So these four are out completely because these are dorsal column. They don't carry pain sensation. Let's look at D. Okay, so why is this wrong here? Because this is ipsilateral, and we know that the spinothalamic tract crosses at the level or, yeah, crosses in the spinal cord, exactly. So it crosses here, and this will it will be C here, the lateral spinothalamic tract. Yep, exactly. Good. So this was some sort of basic tract information. Now let's move on to lesions. So this 22-year-old man, I made up this scenario just so you guys should be aware of this distinction, all right? A 22-year-old man is brought to the ER 30 minutes after being involved in a high-speed motor vehicle collision. After examination, he has severe upper back pain and was unable to move his legs. His pulse was 58, respirations were 17 and regular, and blood pressure is 89/59. Pulse oximetry on room air shows an oxygen saturation of 98%. He has flaccid paralysis and absent reflexes in both extremities. Sensory examination shows absent sensation below the level of the nipples, including absent sensation in the perianal region. Rectal examination discloses no discernible resting tone, and squeezing the glans penis does not elicit anal sphincter contraction. Okay. A whole body CT scan reveals isolated burst fracture of the T3 vertebra. What condition is the patient suffering from? Okay. Okay. All right. So let's first talk about the differences between spinal shock and neurogenic shock. Spinal shock is when there's an acute spinal cord injury. The axons surrounding the injury temporarily don't conduct. So you have Areez reflex, you have flaccid paralysis. Neurogenic shock refers to when there's a lesion in the spinal cord. If that damages the intermediolateral horn of the spinal cord, which carries the sympathetic fibers, if the sympathetic fibers are damaged, that will lead to vasodilation, massive systemic vasodilation, and so there'll be a drop in blood pressure. This person has low blood pressure, plus he has areflexia. So he has both spinal shock and neurogenic shock, all right? So the answer is C. You can see that here. Spinal shock is an immediate temporary loss of power, sensation, and reflexes below the level of injury. Neurogenic shock is sudden loss of sympathetic signals, all right? Now, both of them have flaccid paralysis, but the mechanism of spinal shock is, so neurogenic shock increases blood pressure. No, neurogenic shock would, neurogenic shock is a damage to the sympathetic fibers. Sympathetic fibers cause vasoconstriction. So when there's a damage to the sympathetic fibers in the spinal cord, that would cause vasodilation. And so systemic vascular resistance would fall. That would drop blood pressure and the patient would go into shock, all right? Spinal shock is something different. It refers to areflexia after acute spinal cord injury. All right, so here you see this here. Disruption of autonomic pathways equals results in loss of sympathetic tone and vasodilation. That causes hemodynamic instability. All right. Now, let's move on to the next one here. 62-year-old woman with type 2 diabetes mellitus comes to the physician because of a 1-year history of progressively worsening paresthesia in her limb. All right, she has accidentally burned her fingers on hot dishes several times. She was involved in a motor vehicle accident 3 years ago. Temperature sensation is absent from the upper limbs and upper chest bilaterally. All right, further evaluation of this patient is most likely to show which of the following findings. So she has no temperature sensation bilaterally in the upper limbs and in the chest. What more? And she has a history of trauma. Okay. Okay, good. So exaggerated biceps reflexes, this person has no evidence of upper motor neuron lesions. Absent anal wink reflex, that would be more in something you would call cauda equina syndrome. Deviation of the jaw, that is a lesion of the mandibular nerve, the mandibular branch of the trigeminal nerve. This person would have drooping of the eyelid because this person has something called central cord syndrome or syringomyelia. That's one of the causes of central cord syndrome. That compresses on spinothalamic fibers and disrupts pain and temperature sensations from the upper limbs, because I told you that in the spinothalamic tract, fibers carrying sensation from the upper limb are medially located. And so when the central cord expands, that compresses on these fibers and causes their dysfunction. If that cavitation in the central part of the cord, the central canal, if that expands a bit more, that will compress on sympathetic fibers located in the intermediolateral horn of the spinal cord. That will cause Horner syndrome. which manifests with drooping of the eyelid, right? Ptosis, and it will also cause meiosis, and it will also cause anhidrosis, right? So I just made this table for you guys to as a summary of all the spinal cord syndromes. The first one you should know about is spinal muscular atrophy. This is also called Wernicke-Hoffmann disease. The important thing you need to know is that this involves degeneration of the anterior horn cells only, all right? So they're symmetric, that's important, and there's only lower motor neuron finding. And the other important finding is tongue fasciculations, all right? The next one is amyotrophic lateral sclerosis. That is a combined upper motor neuron, corticospinal tract, and anterior horn degeneration. So you would get a combined upper motor neuron and lower motor neuron type of clinical presentation. There's no sensory deficits. And it's important for you guys to know that this gene here, the superoxide dismutase 1 gene, is often mutated in these patients, all right? The third lesion you guys should be aware of is called tabes dorsalis. It's a manifestation of tertiary syphilis. It causes degeneration of the dorsal column medial lemniscus pathway, which results in loss of vibration, proprioception, and fine touch sensations. No other sensory or motor deficits. How you would see that in an exam, for instance, is they would describe a patient with a suggestive history. So this patient has had many sexual partners, has had unprotected intercourse. This patient may have a history of STDs. Also, this person may have other manifestations of syphilis. So this guy may have a genital ulcer which resolved, then he had a skin rash, so these findings you would expect as well. All right. The next thing you guys should be aware of, and this comes up in exams quite a bit, is vitamin B12 deficiency. This causes degeneration of the corticospinal tract and dorsal column. This is called subacute combined degeneration. So guy would present with findings suggesting dysfunction of the dorsal column pathway like ataxia, paresthesia, impaired position and vibration sense. Also, he would present with spastic type of paralysis, hyperreflexia. Another important finding this guy would have is he would complain of anemia. So if they present to your patient with fatigue and palpitations or angina, these sorts of findings and headache and lightheadedness, maybe they're describing an anemic patient because these are all symptoms of anemia. In the case that the guy has anemia and they give you a low hemoglobin, the first thing that should come to your mind is vitamin B12 deficiency. The other lab findings you would see is homocystinemia and homocystinuria. I don't think this is important for you guys to know. Vitamin B12, there's a few etiologies or causes you should be aware of. Intrinsic factor is produced by parietal cells of the stomach. So whenever a guy has a bariatric surgery or gastrectomy for peptic ulcer disease, for gastric cancer, he would be prone to developing B12 deficiency because stomach isn't producing intrinsic factor anymore. So in an exam question, you'll see in a scenario later that they usually tell you that the patient has had a history of peptic ulcer disease and needed gastrectomy or has had gastric cancer. The other cause would be something like inflammatory bowel disease or some cause of malabsorption. These findings, plus this picture of degeneration of corticospinal tract and dorsal column pathway, should lead you to vitamin B12 deficiency. The last one you should be aware of is Chaudhri syndrome. This occurs due to an IV disc herniation or tumor. This manifests with radicular pain, which is basically shooting pain from the back to the leg, and absent knee and ankle deep tendon reflexes. These patients would also lose bladder control, anal incontinence, fecal incontinence, and they would have something called saddle anesthesia. Around in the perianal region, they would lose sensation. So these are all findings of Chaudhri syndrome. What the person in the scenario had, the person who was cooking and had bilateral loss of pain and temperature sensation, was syringomyelia. It can be congenital, like an Arnold-Chiari malformation, or is associated with tumors, post-traumatic, like the person in the scenario. It causes cavitation of the central cord of the central canal of the spinal cord. It's usually in the cervical segments. It manifests with bilateral loss of pain and temperature at the level of the lesion. As disease progresses, there is muscle weakness because of involvement of the anterior horn cells, and involvement of the intermedial lateral cell columns would lead to Horner syndrome. Right, so three things you should be aware of. Spinothalamic, if the disease extends a bit, it will involve the anterior horn cells. If it progresses a bit more, it will involve the sympathetic fibers. All right, these diagnosis, treatment, you don't need to know. This is another scenario just to show you guys, this is the way it always comes in an exam, syringomyelia. It's a small woman, it's a woman, a young woman usually, worsening occipital headaches. This is a sign of brain tumors, all right? This is a red flag for brain tumors. She recently burned herself again while cooking after keeping her hand on a pan that did not feel hot when touched. All right. The patient has also been experiencing worsening headaches that keep waking her up from sleep. Again, this is a sign of brain tumors. So this is the classic case of syringomyelia you guys should be aware of. Now, this is a 54-year-old man who comes to the physician because of generalized fatigue and numbness in his legs and toes for 6 months. All right. See. Yeah, good. So this guy has a history of gastrectomy for peptic ulcer disease. He has a broad-based gait, and he when he stands with his feet together and closes his eyes, he sways a bit, which is called the Romberg test. It suggests ataxia. You check his hemoglobin concentration; it's low, which suggests that this guy has anemia, which should lead you to concluding that this guy has vitamin B12 deficiency. Syphilis, it won't be syphilis because this guy has no history of syphilis. Multiple sclerosis, which you diagnose it by seeing these oligoclonal bands. This would usually manifest in a young woman, right? Multiple sclerosis, 20 to 30-year-old woman, and you wouldn't see anemia. Now, this is another question. A 20-year-old male comes to the ER after sustaining a stab wound. He has weakness and numbness of the lower extremities. There is a laceration on his back next to the vertebral column at T10. Now, right-sided flaccid paralysis with ipsilateral diminished vibratory sense ipsilaterally, right? So you guys don't need me to read the scenario, that's all right. Okay, good. So this guy has Brown-Séquard syndrome. Okay, so these are, I've just made another table for you guys to see revise the major incomplete spinal cord syndrome. Central cord syndrome is the classic syringomyelia case we discussed previously. Anterior cord syndrome. With anterior cord syndrome, they would usually give a guy with a history of a major surgery or a major traffic accident, and this guy has lost a lot of blood. Or maybe a woman who underwent like a complicated pregnancy in where there was prolonged bleeding after delivery. There was prolonged bleeding. These guys can have damage to the anterior spinal artery or decreased flow through it, which causes ischemia and infarction of the anterior 2/3 of the spinal cord. This manifests with bilateral upper motor neuron lesions and loss of pain and temperature sensations. Importantly, dorsal column sensations remain intact. All right, posterior cord syndrome, it usually the cause is usually an occlusion of the posterior spinal artery, or as we told you, multiple sclerosis, or even tabes dorsalis. Brown-Séquard syndrome is a hemisection of the spinal cord, and these are the 5 findings which you will see in a patient with Brown-Séquard syndrome. Okay, so these are the findings. Number 1 is complete sensory loss at the level of the lesion because of involvement of the dorsal root. There's a lower motor neuron findings at the level of the lesion. There are upper motor neuron findings below the level of the lesion ipsilaterally. There is loss of dorsal column sensations below the level of the lesion ipsilaterally. And there's a loss of spinothalamic sensations below the level of the lesions contralaterally. All right. So these are 5 findings which you will see in a Brown-Séquard patient. Now you guys can read the scenario and tell me what this is as well. Okay. All right. One more and then we'll discuss this question. All right. So again, this patient was a male who was brought to the ER because of a knife wound to his back. Okay, so an examination shows a 5 centimeter deep stab wound at the level of T9. He withdraws his foot to pain, which means spinothalamic sensations are intact, but is unable to sense vibration and proprioception. This corresponds to conscious proprioception. All right. Sensation in the left leg is normal. Motor strength is unaffected, which means corticospinal tract is unaffected. Which of the following structures is most likely damaged? So this person has posterior cord syndrome. This person has bilateral loss of dorsal column sensations. This person has a unilateral loss of dorsal column sensations because of trauma. Dorsal root lesions would involve complete loss of sensation at the level of the lesion. All right. Central spinal cord gray matter. That doesn't really say anything. Lateral corticospinal tract, no motor neuron findings. This artery here, artery of Adam QX, basically the anterior spinal artery supplies the anterior 2/3 of the spinal cord up until the level of T8 spinal segment. Below that, this artery, all right? Yeah, it's the T8 artery, exactly. So below T8, this artery would supply the anterior 2/3 of the spinal cord. All right, so what about this question though? Okay. Okay, good. So again, this scenario, I've picked classical scenarios for you guys because this is how they always give them in exams, right? So again, this woman had a complicated pregnancy. She lost a lot of blood. This caused ischemia of the anterior 2/3 of the spinal cord, which resulted in a bilateral infarction of the corticospinal tract. So this person has anterior cord syndrome. Habeas dorsalis or anything, this guy doesn't have any dorsal column loss, all right? And does this question make sense to everyone? Could you repeat? Okay. So yeah, we'll repeat this one more time. So the classical scenario for anterior cord syndrome is a person who has lost a lot of blood. That's how they will always give it to you in second year and in step one, all right? So it may be an aneurysm repair, an abdominal aortic aneurysm repair. It could be a complicated pregnancy or another complicated surgery. These patients lose blood. They have decreased blood flow through the anterior spinal artery. And so these guys get infarction of the anterior 2/3 of the spinal cord. The examination in these patients will reveal bilateral loss of spinothalamic sensations below the level of the lesion. So this is bilateral loss of spinothalamic sensations below the level of the lesion. Dorsal column sensations are intact. Bilateral loss of motor function below the level of the lesion. So this indicates that there is infarction of the anterior 2/3 of the spinal cord with sparing of the dorsal column, which is in the posterior 1/3. All right. Now, so we're done with spinal cord lesions. Any questions about spinal cord lesions you guys want to revise or anything? Any confusions, any syndromes you have any problems with? Complete transections? Complete transections would pretty much present with every single dysfunction of every single tract. So in case if this person had, for example, loss of dorsal column sensations as well bilaterally, you would suspect a complete transection. All right. Friedreich ataxia. Did you guys take Friedreich ataxia? Really? So in Friedreich ataxia, as far as I remember it, I didn't know you guys took it. There's usually a syndrome which is caused by a trinucleotide repeat expansion, and it manifests with ataxia, and it also manifests with yeah. So it's syndromic, and there's other associated lesions. There's some dysmorphisms of the feet in these patients. There's scoliosis of the spine. There's diabetes. Yeah. So it's a syndromic cause. If they give you a guy with obvious dysmorphic features, then you should suspect Friedreich ataxia. Heart failure, exactly, because it causes something called hypertrophic cardiomyopathy. All right. It's good that you guys took it. We didn't take Friedreich ataxia as well. And these patients are usually susceptible to developing diabetes. I didn't know you guys took it. Otherwise, I would have included the question. But again, Friedreich ataxia, if you have a guy with, firstly, he should be young because it's a syndrome. He has obvious dysmorphic features of the feet. He has scoliosis of the spine. He has heart problems like hypertrophic cardiomyopathy. He has diabetes. He has ataxia. Then you had and seizures, basically. So you would suspect Friedreich ataxia. That's the classic scenario. All right. All right. So let's move on to cranial nerve palsies. I've made this table for you guys. Do you want me to go through it, or should we skip it and go straight to questions? Skip. All right. Skip if you want. I'm here for you guys. What do you want? Skip. All right. Can we go back to it? Sure. So, okay, so we'll use this table to basically discuss after we do a question, I mean. All right, sure, no problem. So before we go into questions, these are some findings you have to be aware of. This eye is deviated down and out. If you see the eyelid here is drooped, if you see the pupil is dilated, this is the classic finding of an oculomotor nerve palsy. Eye deviated down and out, ptosis and mydriasis. All right. Causes of oculomotor nerve palsy. Obviously, it could be in the brainstem, a brainstem lesion. Peripherally, an aneurysm in the posterior communicating artery of the brain in the circle of Willis. That usually compresses on the posterior, the oculomotor nerve and causes cranial nerve 3 palsy. So PCA aneurysm, that's one cause. Uncal herniation or transtentorial herniation of the brain is another cause. Diabetes, some diabetes present with isolated cranial nerve 3 palsy. So diabetes is another important cause, all right? So uncal herniation, posterior communicating artery aneurysm, these are important causes of oculomotor nerve palsies. This is, you see this guy, guy's eye deviated medially. That means he has paralysis of the lateral rectus muscle, which means he has, so he has paralysis of the lateral rectus muscle, and this would be an abducens nerve palsy. Eye deviated medially. Good. This is a facial nerve palsy. You see, these are some important terminology you guys should be aware of. Loss of wrinkling of the forehead, drooping of the eyelid, loss of nasolabial fold, all right? These three buzzwords you should keep in your mind. Wrinkling of the forehead, drooping of the eyelid, and loss of nasolabial fold. If they describe a guy with all of these three findings, that means it's a peripheral lesion in the facial nerve, a lower motor neuron lesion. If they describe these findings, but they say the guy can still wrinkle his forehead, then it's an upper motor neuron lesion, all right? This is the pathway of the facial nerve. You see the upper part is bilaterally innervated. The motor cortex, the red fiber here, and the blue fiber here is bilateral innervation. But the lower part of the nucleus is only contralaterally innervated. So if there's an upper motor neuron lesion here, this pathway is still intact. So the forehead will be okay. So the guy will still be able to wrinkle his forehead. But the innervation to the lower division will be lost. And the guy will have loss of nasolabial fold, all right? And when he smiles, he can't smile on the affected side. No, if these findings are there with fairing of the forehead, lesion is contralateral upper motor neuron lesion. If the whole facial, the face is affected, it's ipsilateral facial nerve palsy. What's this? This is a hypoglossal nerve palsy. This is just to remind you, because contralateral, ipsilateral gets even me a bit confused sometimes, that the hypoglossal nerve palsies always deviate towards the side of the lesion, all right? Tongue deviates towards the side of the lesion in a hypoglossal nerve lesion. So how I usually remember it, deviation of the jaw and deviation of the tongue is towards the side of the lesion. Deviation of the uvula is away from the side of the lesion. If the uvula is deviated, the vagus nerve would be affected. If the jaw is deviated, the mandibular nerve would be affected. If the tongue is deviated, hypoglossal nerve would be affected. But remember, jaw and tongue, they're close together, so they deviate towards the side of the lesion. Uvula deviates away. All right. Now, so you guys can do this question and then we'll discuss it. All right. Okay, B. One guy says B. It's not B, by the way, so have another guess. B. Okay. Okay, sure. So this 55-year-old woman has a 1 year history of left-sided tinnitus. Is diagnosed with a tumor of the left jugular fossa. So this woman has a tumor of the left jugular fossa. If you remember the base of the skull, there's different holes which nerves pass through, right? Which three nerves pass through the jugular foramen? Which three nerves pass through the jugular foramen? Okay, 9, 10, and 11. Good. So just to review, ophthalmic passes through cribriform plate. Optic nerve passes through the optic canal. Oculomotor, trochlear, ophthalmic, and abducens pass through superior orbital fissure. Maxillary passes through foramen rotundum. Mandibular passes through foramen ovale. Facial and vestibulocochlear pass through the internal acoustic meatus. 9, 10, and 11, glossopharyngeal, vagus, and spinal accessory pass through jugular foramen. Hypoglossal nerve passes through the foramen magnum, right? So since this patient has the tumor of the left jugular fossa, this would compress nerves passing through the jugular foramen. So our only three options are 9, 10, and 11. So that rules out A, hypoglossal nerve, that doesn't pass through jugular foramen. B, closing of the jaw is mandibular nerve, doesn't pass through jugular foramen. All right. Equilibrium and balance is vestibulocochlear, doesn't pass through the jugular foramen. Taste sensation to the anterior two-thirds, anterior tip of the tongue is mediated by the facial nerve. That doesn't pass through the jugular foramen. Afferent limb of the cough reflex. The cough reflex is mediated by laryngeal nerves. So they obviously don't pass through the jugular foramen. Now, afferent limb of the gag reflex. Good. So the other hint that they gave you in the scenario, other than the jugular foramen, is decreased production of saliva from the parotid gland. You guys should know that the glossopharyngeal nerve innervates the parotid gland. The facial nerve innervates the submandibular and sublingual glands. So there's three major salivary glands, and there's a number of minor salivary glands. The three major salivary glands are parotid, submandibular, sublingual. Glossopharyngeal supply the submandibular gland. Facial supply the glossopharyngeal supplies the parotid gland. Facial supplies the submandibular and sublingual gland. This guy has a glossopharyngeal nerve lesion. Glossopharyngeal nerve also carries sensation from the throat. So it mediates the afferent limb of the gag reflex. So the answer is D. All right. So if you guys can see, let's go back here. Cranial and right, loss of gag reflex, loss of sensation general taste in the posterior one-third of the tongue. So if the question said loss of taste sensation in on the posterior one-third of the tongue, this would be glossopharyngeal. This is mediated by facial nerve. All right. Yeah. Right. The next question. Any questions with any problems with that question, by the way? No? Okay. Okay. Okay, good. So yeah, you all got it right. This person has a trochlear nerve lesion because let me actually show you here. Yeah, so this is a good image. Basically, the trochlear nerve supplies the superior oblique muscle, and that in towards the eye. So imagine if both these eyes are aligned straight, and you have a trochlear nerve lesion on my right side, the eye will extort, so it will turn this way. So what the person will do is he'll tilt his head towards the opposite side, and this will bring the eye back in alignment. All right. The eye is deviated upwards, so there's hypertropia and it's extorted. And the classic finding that you will always see in a case scenario with a trochlear nerve lesion, you guys should be aware of this, that they will always have difficulty looking down and doing something. All right. So they'll have difficulty reading a book. They'll have difficulty climbing stairs, going downstairs. They will have difficulty typing or while buttoning their shirt because the superior oblique muscle depresses and in towards the eye. So they're able to look down. When you're looking down, you're using superior oblique. So you will always have problems in people. So basically, if you have a person who has problems reading a book and his head is tilted, this person is classic for trochlear nerve palsy. All right. Next question. Anyone? Okay. Okay. C. All right. So this person is a 65-year-old man with double vision that began in the morning. He has a history of diabetes and he smokes cigarettes. The eye is deviated down and out. What lesion was that? What palsy was that? That was oculomotor nerve palsy. Yeah. So extraocular movements of the left eye is normal, but the patient complains when asked to look to the left. So he can't adduct his right eye, which is medial rectus, which is supplied by oculomotor nerve. Now, loss of right nasolabial fold, that would be facial nerve palsy, peripheral or central. That doesn't really matter. Absent corneal reflex. The corneal reflex is basically when someone uses a sort of cotton swab something and he brushes your eye and you blink. So the sensation from the eye is actually carried by ophthalmic nerve. The sensory supply to the eye is by the ophthalmic. Yeah. The motor supply to the eye is by 3, 4, and 6, but the sensory supply is by the ophthalmic. The motor supply, which causes you to blink, is by facial. Right? So this guy will have upper eyelid droop because the oculomotor nerve also supplies a muscle called levator palpebris superioris. All right? It wouldn't be D because this guy doesn't have Horner syndrome. This guy does have ptosis, but he wouldn't have anhydrosis. This would signify Horner syndrome. All right? What's the answer? The answer is C, upper eyelid droop. Because this is the right answer because paralysis of levator palpebris superioris. All right. This is a 25 rule. So basically, this question is asking you which nerves pass through the superior orbital fissure. DV1. Yep. So the nerves which pass through the superior orbital fissure are 3, 4, V1, and 6. All right, the first division of 5, yes, ophthalmic nerve. Good. So this is a good time to kind of revise these reflexes because they can get a bit tricky. So the corneal reflex, where the guy touches your eye and you blink, the sensory arm is by the ophthalmic. The motor arm, which causes you to blink, is by contraction of a muscle called orbicularis oculi. That's supplied by the facial nerve. The lacrimation reflex is when the guy does the same thing and you tear up. Again, sensation from the eye is carried from V1. Efferent limb or motor limb is carried by facial because the facial nerve also supplies the lacrimal gland because it synapses with the pterygopalatine ganglion. All right. The jaw jerk reflex, the mandibular branch of the trigeminal nerve, is both sensory and motor. So it mediates the afferent limb as well as the efferent limb. The pupillary right reflex is when they have a pen light and they shine it in your eyes and your pupil constricts. That obviously that light hits the retina, so the optic nerve actually transmits that signal back to the brain, to your primary visual cortex, and your pupil is constricted because the oculomotor nerve supplies the ciliary muscle. The gag reflex, we saw a question on this previously. The sensory limb is carried by glossopharyngeal. Motor limb is carried by vagus nerve. I also included these reflexes, the spinal reflexes. You guys should be aware of this, especially these two at the top here. Achilles reflex is S1, S2. Patellar reflex is S2, 3, 4. Remember these ones, all right? Now, so an otherwise healthy man comes. Can you explain cough reflex? Cough reflex is basically whenever there's some irritation to your upper airway and you cough. So actually, it has nothing to do with the nerves that we're studying. It has more to do with the respiratory system and the laryngeal nerve, because it's actually stimulated by the laryngeal muscles, like the internal laryngeal nerve, superior laryngeal nerve, recurrent laryngeal nerve, these sorts of muscles. All right, these mediate the cough reflex. And there is also the diaphragm is involved as well, because you close your epiglottis and you generate pressure and then you release immediately and that causes you to cough. So it's not really related to, cranial nerve. All right. So this guy presents with a painful ulcer on his tongue for 3 days. Examination shows this ulcer to be on the lateral aspect of the tongue, adjacent to his first molar. So that's within the anterior 2/3 of the tongue, right? A lesion of the cranial nerve responsible for the transmission of pain from this ulcer would most likely result in which of the following? So firstly, which nerve carries pain sensations from the anterior 2/3 of the tongue? No, it doesn't. Yeah, facial nerve carries taste sensations from the anterior 2/3 of the tongue. The mandibular nerve, branch of the trigeminal, carries general sensation like pain and temperature and touch. All right. Yeah, so it's a bit confusing. So anterior 2/3 facial nerve taste, mandibular nerve general, posterior 1/3 glossopharyngeal taste and general. Difficulty chewing exactly because the mandibular branch is responsible for mastication. It supplies 4 muscles called masseter, temporalis, medial pterygoid, lateral pterygoid. Why is it not A? Why do you think it's not A? Which nerve is this? Maxillary, exactly. Good. So, and loss of taste from the supraglottic region would be vagus nerve. Diminished gag reflex, that would be 9 and 10, glossopharyngeal and vagus nerve. Lateral deviation of the tongue is hypoglossal nerve. Sensation to be, okay. 7. All right, so no, 7 supplies motor to the face, all right? It has, facial nerve has nothing to do with sensory supply to the face. Facial nerve supplies motor to all the face, plus taste sensation to the tongue. All right, so here's a good diagram for you guys. So this is general sensation and this is taste sensation. General sensation, anterior 2/3, is by the lingual branch of the mandibular nerve. Taste sensation to the anterior 2/3 is by the facial nerve. The posterior 1/3, general and taste, is carried by glossopharyngeal. Then you go further back and you reach the supraglottic region. That is taste and general is by vagus nerve. All right. You should, yeah, you keep this straight in your mind, right? So we're done with cranial nerves. Does anyone have any questions or any confusion regarding cranial nerve palsies? I put this table up for you guys to revise here. If you have any questions from this table, you can ask. Or can we move on to brainstem? Sensory and taste for anterior, posterior again for tongue. Okay. Okay. So taste, the tongue sensations to the tongue. Okay, let me just explain this tongue thing. Sensations to the tongue can be general and they can be taste, right? The tongue is also divided into anterior 2/3, posterior 1/3. General to the anterior 2/3 of the tongue. General to the anterior 2/3 of the tongue is carried by mandibular nerve, which is V3. Taste to the anterior 2/3 of the tongue is carried by facial nerve. So general is carried by mandibular, taste is carried by facial. The things behind it, you don't need to make this distinction because the posterior 1/3, both general and taste are carried by glossopharyngeal. And supraglottic region, taste and general is carried by vagus. So the only confusion comes in the anterior 2/3 of the tongue. You have to distinguish between general sensations like pain, temperature, touch, and taste sensations. General is mediated by mandibular nerve, taste is mediated, carried by facial nerve. Okay. All right. So you guys probably would have heard of the rule of 4s when doing brainstem. I like to add a 4th step to it, another step to it, and that is how do you figure out whether a lesion is in the brainstem or the spinal cord? So if you have a scenario of a guy who has contralateral or one-sided paralysis of the arms and legs, spastic type of paralysis, and he has sensory loss, how do you know whether this guy has a spinal cord lesion or whether this lesion is in the brainstem? So the first thing you should ask is, does the guy have head and neck symptoms? Exactly. So if a guy has head and neck symptoms, which suggest any cranial nerve palsy, that suggests a brainstem lesion. So that's the first thing you should always look for in an exam, in an MCQ. Always look for whether the guy has head and neck symptoms. If the guy does, he has a brainstem lesion. If he doesn't, then you can move on to spinal cord lesion. All right, so now the guy has brainstem lesion, has a brainstem lesion. Now you need to contralateral upper motor neuron lesion. Yeah, but you don't know if it's contralateral, right? From a scenario, you wouldn't get if it's contralateral. You have to discern whether it's contralateral or not by your knowledge of sort of the other findings the guy has. Okay. So if the reliable method is to look for head and neck symptoms. If the guy has head and neck symptoms, it's a lesion in the brainstem because the cranial nerves supply the head and neck. Okay, the spinal nerves supply the rest of the body. So that's step one. Step two is whether you figuring out it's medial or lateral, and then by determining which specific palsy you have. If you have a facial nerve palsy, then it's a lesion in the pons. If you have an oculomotor nerve palsy, it's a lesion in the midbrain. All right. So by the specific palsy, you can tell whether it's midbrain, pons, or medulla. But you also have to figure out whether it's medial or lateral. So the way I usually have learned it is if I draw a brainstem here, you have midline structures that begin with M, right? So the middle structures begin with an M, motor nuclei, medial longitudinal fasciculus, medial lemniscus, and motor tract. If you see a guy, and these motor nuclei are the somatic nuclei, all right? So these are 3, 4, 6, and 12, oculomotor, trochlear, abducens, and hypoglossal. If you see any palsy in them, if you see a guy with cranial nerve palsy due to one of these lesions or a lesion in one of these nuclei, it's a midline lesion. If you see a guy with dorsal column sensation loss, it's a midline lesion. If you see a guy with contralateral upper motor neuron symptoms, it's a midline lesion. Any one of these M structures, if you see them affected, it's a medial lesion. All right. Then you have side structures, and they all begin with an S. So you have side structures, 4 of them, midline structures, 4 of them. The midline structures all begin with an M. The side structures all begin with an S. So if you see a guy with ataxia, loss of contralateral pain and temperature sensation, any facial anesthesia. So if a guy can't feel pain on the face, if a guy has Horner syndrome, if you see these findings, that means the lesion is laterally located. Does this make sense to everyone? Once you see these findings and you've discerned whether the lesion is medial or lateral, now all you have to do is look at the specific cranial nerve affected. So if it's a facial nerve, then it's medial pontine syndrome or ventral pontine syndrome. If it's the hypoglossal nerve, is medial medullary syndrome. If it's vagus nerve affected, probably lateral medullary syndrome. All right, because the motor nuclei aren't affected. These would be affected in lateral medullary syndrome. Does this all make sense to everyone? The rule of force thing? Yep. Okay, so let's do some questions regarding that. And the easy way to remember the motor nuclei are that you have 12 cranial nerves, and all the motor nuclei are multiples of 12. So 3, 4, 6, and 12. That's how I usually keep them straight in my head. All right, so this is another example for you, the rule of force applied here. This is the motor path with the corticospinal tract, medial lemniscus, medial longitudinal fasciculus, the motor nuclei, which are 3, 4, 6, and 12. A lesion in any one of them, if you see them in a question stem, it's a midline lesion. If you see any one of these pathways affected, loss of pain and temperature, loss of facial sensations, loss of Horner syndrome, for example, the lesion is lateral. Okay. Now this is a question here. Okay, so that's good. You've diagnosed this lesion to be in the lateral medulla. Then the next question is, what's the supply of the lateral medulla? And that's posterior inferior salivary artery, which is pica. All right. So how do you diagnose it? Again, if you follow those 4 steps, first figure out whether this is a spinal cord lesion or a brainstem lesion. This guy obviously has head and neck symptoms. Here, constricted pupil, loss of gag reflex. So this is a brainstem lesion. Then you have to figure out medial or lateral. This guy has no motor neuron finding. This guy has left-sided facial analgesia. So this guy has loss of sensation from the face, which means it's a lateral lesion. The next step is figuring out which level of the brainstem. This guy has lots of vocal cords, which suggests a vagus nerve palsy, or paralysis of the vocal cord, which is supplied by the vagus nerve. That means in the medulla. So lateral medullary syndrome. Which artery supplies it? Which is pica, right? So this is the way I usually draw a table when I went into the neuro exam. That paper you get, I just drew this table quickly in case I forget. So this is the blood supply of the midbrain, the posterior cerebral artery. This is the medial pons basilar artery. The lateral pons is ICA. Okay. The anterior spinal artery is supplying the middle part of the medulla. The posterior inferior cerebellar artery is supplying the lateral part of the medulla. All right. The medial medulla is anterior spinal. Lateral medullary syndrome is FICA. Basilar artery supplies the medial part of the pons. ICA supplies the lateral pons. Okay. So again, the same question basically, but I've just switched around some findings. Okay. Okay. So let's figure this out. So this person cannot move upper and lower left part of this extremity, so has paralysis. So automatically you know it's a midline lesion. Deep tendon reflexes again. All right. He has a broad-based gait, which means medial lemniscus is affected, so midline lesion. Sensory and motor exam of the face is unremarkable. So sensation is normal. So again, going with sensation of the face is normal. So again, it's not a lateral lesion. However, his tongue is deviated to the left side upon protrusion. Okay. Which artery is affected? Anterior spinal artery. Exactly. So if you go here again, the medial part of the medulla is supplied by anterior spinal artery. Which side is this lesion in, by the way? Left or right? Okay. Let me check. Right, left. Yeah, good. So hypoglossal jaw and tongue are towards the lesion. Uvula is away from the lesion. All right. Okay. So this part. So this is a 65-year-old man with squamous cell carcinoma of the lung. You learn more about this in third year, that people with lung cancer or lung disease in general can develop something called SIADH. All right. This means ADH is released and causes water reabsorption, and that causes dilutional hyponatremia. Then he was started on hypertonic saline, and he becomes quadriplegic. Central pontine myelinolysis. Yeah. So the concept here, and this question did come in our exam as well, midterm exam, that if you have a guy with hyponatremia, you should always correct the hyponatremia slowly. Otherwise, you would risk causing osmotic demyelination, because if you correct the serum sodium too quickly, the osmolarity would go up, and all of those, the cell would basically get dehydrated, right? If the cell gets dehydrated, and that would result in demyelination of the basilar part of the pons. And the basilar part of the pons, which is the anterior part of the pons, it contains all those descending cortical spinal fibers, the corticobulbar fibers, and the corticopontine fibers as well. So the guy becomes quadriplegic. Which lecture was this from? This is from the brainstem lecture. Central pontine myelinolysis. Okay. Okay, Sarah, which cranial nerve is affected in this patient? Okay, so this person has loss of motor function to the face. Uh, motor function to the facial muscles is all supplied by the facial nerve. So it's a pontine lesion. So yeah, seven. Yeah, seven. Because this person has a loss of nasolabial fold, loss of taste sensation on the anterior two-thirds of the tongue. The corneal reflex and lacrimation reflex are also absent. And we said that the facial nerve is the motor component of these reflexes, right? This guy also has an abducens nerve lesion. Okay, so everyone said C. All right. So again, if you again apply the same sort of workup, figure out whether the lesion is in the spinal cord or brainstem. This person obviously has head and neck symptoms, so it's a brainstem lesion. Whether it's medial or lateral, this person obviously has sudden onset paralysis, right? So this person has corticospinal lesions as well, which means the lesion is in the middle pons. He has no spinocerebellar, spinothalamic, dorsal column symptoms because of their damage. So the lesion is not lateral, so it's in the medial part of the brainstem. The third step is figuring out midbrain, pons, and medulla. This person has a facial nerve lesion and an abducens nerve lesion, which means it's in the medulla. It's in the pons, right? So it's a ventral pontine syndrome or Millard-Gubler syndrome. If the guy had Horner syndrome, these sorts of things, you would suspect lateral pontine syndrome. Locked-in syndrome is what you get with the previous question. If you get central pontine myelinosis or central pontine myelinolysis or osmotic demyelination, these are all different names for the same thing. You get something called locked-in syndrome, quadriplegia with preservation of eye movements up and down. All right. So the guy usually the question we had and a few other questions I've seen on central pontine myelinolysis is a guy who had their serum sodium corrected too quickly and then only their eye movements were preserved. And so then they learned to communicate by code or something. Because it's below the midbrain. And midbrain contains oculomotor and trochlear nerves. So the functions of those nerves are intact. Okay, so there's this again, so everyone gets the sort of workup you have to do for brainstem lesions. Number one, figure out brainstem or spinal cord, then medial or lateral using the rule of fours. Then the specific cranial nerve you see, according to that, you can tell whether it's in the midbrain, the pons, and the medulla. And then you should keep in mind the blood supply for each part. The midbrain, the whole midbrain is supplied by posterior cerebral. The middle part of the pons is supplied by basilar. Lateral is by ICA. Medial part of the medulla is by anterior spinal. Lateral part is by pica. Right. So another question, again, it's all the same scenario, 65-year-old man, but the findings are a bit different. Actually, yeah. So this is the same scenario, but I'm asking you which artery would be affected in this patient. Okay. Okay, good. Okay. So how did you guys know that this was a lesion in the lateral part of the pons? Lateral pontine syndrome, yeah. So firstly, this guy has vestibulocochlear symptoms like dizziness and nystagmus. That's the first thing. So, and the vestibulocochlear nuclei are found in the lateral part of the midbrain, the junction between the midbrain and the pontomedullary junction. That's where the 4 vestibulocochlear nuclei are found, right? Then you have a facial nerve lesion. You've lost the same findings as the last scenario, plus facial analgesia, which means the trigeminal nucleus is affected, the principal pontine nucleus. And he has loss of spinothalamic sensations as well. That means it's a lateral pons. So it's lateral pontine syndrome. The artery which supplies the lateral pons is ICA. All right. Spinothalamic is involved, so it's located laterally. Yeah. So it's any one of the S structures are involved laterally. I think this is the last question we have. Okay, so let's firstly see what we're looking at. All right. So this is right, this is left. This is obviously a section of the midbrain. You see the oculomotor nerve coming out here. This is right, this is left, all right? This person has nystagmus of the left eye. So when he's asked to look to the left, his left eye abducts, but his right eye doesn't abduct. So there's a dysynchrony in the conjugate gaze of this patient, okay? And so when the right eye doesn't abduct, the left eye, your brain interprets that as the left eye being out of alignment. And so there's a correction movement of the left eye, which is nystagmus. The next question is whether it's right or left. Now, with this question, I'll explain these findings after we know the answer, but this is a case of internuclear ophthalmoplegia. This person likely has multiple sclerosis, and multiple sclerosis causes demyelination, specifically of the medial longitudinal fasciculus. Good. So Faisal, you got it, but you got the side wrong. So the side which is affected is the right side. So it's C. Yeah. So the side which doesn't adduct is the pathological side, all right? Is the ipsilateral side. So the side which there is nystagmus in is the normal side. So for people who couldn't follow this, so this is what happens, okay? So this is you looking normally. This is conjugate gaze to the left, okay? Then if the person is asked to look to the right, this is another case, right? So when the person is asked to look to the right, there's abduction of the right eye, but there's an inability to adduct this eye, okay? So the synchronization is messed up. When this eye doesn't adduct, your brain senses that this eye is out of alignment. So it brings it back, and there's nystagmus in this eye. But this eye is doing its job. It's this eye which is the problem. So the problem is in the eye which doesn't adduct. Okay? For the people who don't know what internuclear ophthalmoplegia is, put simply, there's a part in the pons called the reticular formation. Specifically, it's called the paramedian pontine reticular formation, or the PPRF. This paramedian pontine reticular formation, or PPRF, contains something called the lateral gaze center. Okay, so the name tells you what it does. So the left lateral gaze center in the left side of the pons would cause lateral gaze to the left. So both stimulation of this center would cause both eyes to look to the left. Stimulation of the right lateral gaze center would cause both eyes to look to the right. But this lateral gaze center is controlled by the contralateral frontal eye field, all right? So the contralateral frontal eye field communicates with the lateral gaze center and causes eye movement to the opposite side. So if I stimulate the right frontal eye field, both eyes look to the left. If I stimulate the left frontal eye field, both eyes look to the right. So that's good. So if you think about the paths which were involved here, stimulation of let's say you stimulate the left frontal eye field, that will cause conjugate gaze to the right. That means the abducens nerve on the right side and the oculomotor nerve on the left side must be stimulated. So this example here, the left frontal eye field, it communicates with the right lateral gaze center because it wants to cause movement to the right. This communicates with the abducens nerve of the ipsilateral side, the lateral rectus here, and via the medial longitudinal fasciculus on the right side, it's communicating with the oculomotor nerve nucleus. And stimulation causes adduction. A pathology here in the medial longitudinal fasciculus, this pathway would be normal, this whole pathway, so the eye would abduct, but since this pathway is affected, this eye wouldn't adduct, and there would be nystagmus of this eye. So the classic case of internuclear ophthalmoplegia is in multiple sclerosis, okay? That's the one thing you need to know. And you need to know that the eye which doesn't adduct, the lesion is on that side. Does this make sense to everyone? Yep. Okay. And so we're done with my part. Unrelated, but can you explain hemianopia again? I didn't explain hemianopia. Okay, so, but let's explain it just for your sake. Okay. I know. Okay. All right. So let's say you have two eyes here, and this is the eyeball. There are fibers from the retina here. There's fibers from the retina here. This is the guy's nose, all right? Fibers from retina here, lateral fibers. These are temporal fibers. These are nasal fibers. Okay, so these temporal vision, or the peripheral part of your vision, has these fibers, and has these fibers. So the temporal part of your vision hits the nasal fibers. The nasal part of your vision hits the temporal fibers. So it's like a cross, all right? Then both of these go back through the optic nerve. The ones responsible for the temporal vision, both of them will cross here, right? This part is called the optic chiasm. Okay, and these fibers will run uncrossed. So now what's important to realize here is that the nasal fibers from this side and the nasal fibers from the other side, the nasal fibers from this side and the temporal fibers from the other side here, and this is temporal, and this is temporal, and this is nasal. All right. So the nasal fibers from the temporal fibers from this side and the nasal fibers from this side. All right, it's here. So if there's a lesion here, what will happen? You lose the temporal part of the other eye, and the nasal part of this eye. Okay, does this make sense to you? So if there's a lesion, so depending on where the lesion is, firstly, the nasal fibers are crossing. So if there's a lesion in the optic chiasm, you have loss of temporal vision, bitemporal hemianopia. So if you have this, you will have a loss of vision on this side, on the peripheral part. If you have a lesion after the crossing, you would have contralateral homonymous hemianopia. Okay? Now, this is where it gets slightly confusing. Now, depending on where you are, in the temporal lobe or in the parietal lobe, the findings will be different. If you have a lesion in the temporal lobe, it will cause a loss of vision in the lower quarter of the visual field. Okay, so if you have a lesion in the temporal lobe, you will lose contralaterally this side. Okay, if you have a lesion in the parietal lobe, which is up, you will have something like this. These fibers will be affected. Okay. So ocular motor, optic chiasm equals bitemporal, and after equals contralateral. Yes, because the fibers have crossed already. So if you have a lesion here, you would have bitemporal hemianopia. If you have a lesion after it, you would always have contralateral something. Okay, contralateral something. That something depends on where you are. If you're in the temporal lobe, which is lower down, you will have pie in the sky, right? So you will. This is, where am I? So this is temporal, and this is parietal. So pie in the sky is for temporal lobe lesion. The lower you are, the upper you go, basically. That's how I remember it. Temporal lobe causes the right upper quadrant to be defective, contralaterally. Parietal lobe lesions cause the contralateral lower quadrant to be affected. Now, does that make sense to you so far? All right, but there's one more thing you need to know. Now, let's say you have a lesion in the visual cortex. In the occipital cortex, you have a lesion. The occipital cortex, and these, by the way, all of this usually happens because of a stroke, all right? Except the optic chiasm part, the pituitary adenomas cause this, bitemporal hemianopia. Right, good, Faisal. So the occipital cortex has a dual blood supply, the middle cerebral plus posterior cerebral. So if you have a lesion in the occipital cortex, a stroke, right, yeah, not PICA, PCA, posterior cerebral artery, okay? So you will have something like this. If you have a lesion in the right occipital lobe, you will have something like this, and like this. So both eyes would, visual field would be lost contralaterally, but there would be this middle part would be spared. Like Faisal said, this would be macular sparing. All right. So just to revise, lesion in the optic chiasm, bitemporal hemianopia. Lesion in the parietal lobe, which is contralateral inferior quadrantanopia. All right. Basically, this quarter on the lower side, a quarter of the lower side on the contralateral side. A lesion in the temporal lobe, which is lower down, causes a pie in the sky sort of defect. contralateral superior quadrantanopia. That's the third lesion. If you have, then you could have a lesion in the occipital cortex. That would be contralateral homonymous hemianopia with macular sparing because of a dual blood supply. Does this make sense? Okay. Okay, good. So I think Eman can take it from here.
Hi everyone, how are you? I hope you all are doing well. Just give me 1 second. I'm going to turn my camera on. I'm just getting seated comfortably. Okay. Okay, are you guys able to see me properly like this? Perfect, okay. So I know you guys just did like a brainstem review, if I'm not wrong, brainstem and spinal cord with Areez. I hope it was helpful. I know he's a great tutor, mashallah. So I'm going to be covering the cerebrum and its blood flow, and we're going to be going over questions that I've compiled from different sources. And we're only going to go over about 10 because I don't want it to be too heavy, and there is a lot of repetition throughout the questions that you will practice. So we're just going to go through a few of them that I feel are really great for like hammering in those concepts that are really important for you guys to know, okay? So this is my presentation that I'll share with you after as well. So I'm just going to minimize myself here. And I'd really like for you guys to be interactive just because of course it'll help you more in the end, but that's all. Inshallah, I wanted to benefit you all, okay? So let's just get started then without delay. Before we start, I wanted to ask those who are attending, what is something that you guys had the most difficulty with in cerebrum, just so I can focus on that a little bit more throughout the session or towards the end? Was there anything specific that you guys found more confusing or that you weren't able to grasp as quickly that you feel like you need to review? Okay, so nobody's saying anything. Okay, hemianopia or hemianopsia and maybe Gerstmann syndrome. Okay, Gerstmann syndrome. I actually think I forgot to include Gerstmann syndrome in my presentation. So remind me later, and then once I give you guys the presentation at the end, I will include that specifically. I focused more on the actual like cerebral areas, the aphasia, etc., the deficits due to blood flow. So just remind me later, or I'll add it into the PowerPoint before I share it with you guys, okay? All right, so this session's focus is going to be the cerebrum, blood flow, and then the deficits in the cerebrum when there's a stop in blood flow. So that will basically hammer in the concepts of what different parts of the cerebrum are responsible for. And then we'll go along with that and cover the other concepts, okay? So before we start the questions, it's very, very quick review. This is a circle of Willis, as you guys have probably seen now, probably 20 to 30 times. So circle of Willis, this is the circle that they're speaking of. There's a vertebral arteries that branch from the subclavian arteries. This is the anterior spinal artery that branches from those. This gives us the pica, which is very commonly affected in strokes of the brainstem, especially the lateral medulla or lateral medullary syndrome. This is the basilar artery when the vertebral arteries basically come together. Gives you the basilar artery, which gives off the anterior inferior cerebellar arteries. And then you get your superior cerebellar arteries, and you get your posterior cerebral arteries. You get your posterior communicating arteries, and you get your internal carotids. And then from your internal carotids, you get your internal carotid. And from your internal carotids, which come basically like this, you're going to get your middle cerebral artery that goes out laterally this way, and then that way. So left and right. And then you're going to be getting your anterior cerebral arteries on the left and right, and your anterior communicating arteries. So the communicating arteries, there's only anterior and posterior. The posterior is communicating in between the posterior cerebral artery and the internal carotid. And the anterior communicating artery is communicating between the two anterior cerebral arteries, okay? So this is what it looks like on its own. And, oh, the screen is loading for you guys?
Yes, it's loading.
Oh, sorry. I thought you guys were able to see. Wait, let me go back one slide. Just give me 1 second. Wait. Can you guys see it now?
Nope.
That is so odd. Okay. Is it my internet by any chance? It's not my internet.
Maybe try
Maybe-
refreshing the slides.
Sure. Okay. Let's try. Stop share for a second. Okay. Just give me 1 second, guys. Sorry. Okay. Please work. I'm going to share it again, and if it doesn't work, then we'll figure it out. We'll figure it out. Okay. Where did my Zoom go? Okay. Can you guys see this?
Yes.
Yeah.
Okay. Can you see it when I put on slideshow? Can you see it now?
Nope.
Damn. Okay. I guess not. You know what? We're going to keep it like this then for now. And I'm going to just beg you guys to not look to the left, I guess, because I don't know what else to do.
You can drag it to the left.
I'm trying. It's not. Oh. I'm very tech savvy, as you guys can see. Very, very tech savvy at my young age. Anyway, thank you, Nasser. Thank you very much.
No problem.
Okay, so basically, I'll restart very quickly. So you have your vertebral arteries that branch from the subclavian arteries, which are not shown here. They give off your anterior spinal artery, which will run down anterior to your spinal cord. These also give off your picas, left and right, which are very commonly implicated in strokes of the lateral medulla. You guys have probably learned a lot about that, and I'm sure Areez covered it with you guys. Then these two will give you the basilar artery together. Then they will they will give off the anterior inferior cerebellar arteries. And the basilar arteries will also give you your superior cerebellar arteries, your posterior cerebral arteries over here, and then your posterior cerebral arteries will give off the posterior communicating arteries, which communicate with the internal carotid artery. Your internal carotids will come in and give off your middle cerebral arteries to the left and the right, which will run laterally. And then these will give off your anterior cerebral arteries, which are connected with the anterior communicating arteries, okay? Oh, sorry, with the anterior communicating artery, you have one. So the anterior communicating artery makes the anterior cerebral arteries communicate, whereas the posterior communicating artery makes the posterior cerebral artery and the internal carotid artery communicate, okay? This is what I want you guys to know. This is the circle of Willis on its own, or the blood supply of the brain. And then this is it in the context of the actual brain itself. So you see the circle of Willis, you'll see where your internal carotids come in over here. You'll see your middle cerebral arteries being given off over here by the internal carotids. These are your anterior cerebral arteries, which will run anteriorly, go over your corpus callosum and basically give off branches to your anterior and medial cortices, okay? Parts of your cortices. Then here's the anterior communicating artery. This is your posterior communicating artery, your posterior cerebral arteries, your basilar artery, your vertebral arteries on the left and right, pica, anterior inferior cerebellar artery, and pretty self-explanatory. Are you guys clear up until here? Yes, okay, good. Now, here it is in the medial view. Anterior, like I said, running over the corpus callosum, anterior, and then it goes back and it is supplying the medial aspect of your cortex. You have, if you can hear a cat in the background, it's just a cat in our patio. You have your posterior cerebral arteries running to the back. Your middle cerebral artery, you can't really see it here because it's running laterally, and this is a medial view. So it's going to come here and it's going to run laterally to the lateral aspects of your cortices, okay? Is that clear up until now? Those are the three main things that you need to know. Those are the three main vessels that we're going to be talking about when we talk about vascular problems in the brain, okay? Now, why is this important? Because remember that each part of the cortex is responsible for a certain part of your body. This is called the homunculus, as you guys know. So over here, you'll see legs and feet. And then the genitalia, this is all medial. When you move more laterally, in the center, you're going to see the hand. And then when you move even more laterally, you're going to see the face. And then the most lateral aspect is your gums, your tongue, your teeth, your lips. So basically everything oral in your mouth, okay? And it's the same for both motor and sensory. Now remember, medial, lower limbs, lateral, or kind of moving more laterally, upper limbs. Most lateral, you're going to have your head and neck, mostly the oral area. So your face, so your teeth, your gums, your tongue, motor and sensory, okay? Now moving on, this is because there's going to be a question that might come on it. You need to know the embryological origins of each part of the brain, because you might get a question of like, oh, hey, this person has a problem, blah, blah, blah. And they're not going to ask you, hey, how do you take care of this problem? They're going to ask you, what does it originate from, like embryologically? And it's going to sometimes throw you off. So just remember this, like definitely review it. Like even if it's like a last minute review, just remember like, okay, this gives rise to this gives rise to this. So the telencephalon gives you the cerebrum. This is the corpus callosum over here. The diencephalon will give you the center of the brain, and then the midbrain will come from the mesencephalon. The diencephalon will give you your third ventricle, sorry, not the center of the brain, your third ventricle. The mesencephalon over here will give you your pons and cerebellum, and the myelencephalon will give you your medulla oblongata, okay, or just the medulla. So just remember these. So telencephalon, your cerebrum, your cortex, your cortices. Diencephalon is going to be here, your third ventricle. Mesencephalon is going to be your midbrain. Metencephalon is going to be the pons and the cerebellum. Myelencephalon is going to be the medulla oblongata, okay? Now we move into our first question. So as we go through these questions, they're going to be I'm going to be basically touching upon the concepts that are important for you guys to remember. And then if I miss anything, because I'm also doing neuro right now, by the way, in 5th year, so we also do cover these things. But if I do miss anything that is coming on your midterm, please, please, please let me know by the end of the lecture and then, or the end of the review session, and I will add it into the PowerPoint before I share it with you guys tonight, okay? So either way, first question. A 58-year-old hypertensive woman complains of numbness and weakness in her leg and foot. Occlusion of which of the following vessels may be affected? A, anterior cerebral, B, posterior cerebral, C, internal carotid, D, anterior choroidal, or E, middle cerebral artery. What do you guys think? Okay, so Nasha says A. Does anybody else have anything else? Does anybody else have anything else to add on? Any other, does anybody disagree? Okay, so Nasser says A. And before we go into the actual answer, so the important things are leg and foot, occlusion, 58 years old, it doesn't matter. Okay, we know from an older age, it's probably going to be a stroke. But leg and foot, that's the main thing you need to know. So leg and foot, you know, okay, on the homunculus, where is that? And then if we go back a few slides, we know that the leg and foot is over here. And what supplies this? Like Nafsa said, A, anterior cerebral artery. So yes, you are correct, it's anterior cerebral artery. Okay, for the next question. The inability to perform certain types of learned complex movements, referred to as apraxia, usually results from a lesion in which of the following? A, anterior cerebral artery, B, posterior cerebral artery, C, internal carotid, D, anterior choroidal artery, or E, middle cerebral artery. Okay, so Nasser says E. Anybody else have anything to add on or say? Okay. No, so we'll look at the answer. So learned complex movements, apraxia. Oh, sorry, I'm so sorry. Okay. I didn't, when I was editing this, I didn't edit it properly. So, okay. Is it precentral, postcentral, premotor, prefrontal, or primary motor cortex? I know the answer is there, but if you had not known, what would you have said? Definitely C, probably, because it's given right there. But to review basically what each of these mean, and I'm so sorry for that. Learned complex movements, even though we're talking about motor deficits over here, there's inability to do learned complex movements. We need to remember, okay, It's apraxia because it's learned complex. Like you can't perform those certain types of things, but they can generally otherwise move in a certain way. So is it the motor cortex that is affected, or is it the premotor? And in this case, it's going to be the premotor. And we can see over here, you guys can see that, okay, this is the premotor cortex. This is the primary cortex, this is central gyrus. You have the primary sensory cortex behind. So you have the precentral and postcentral, okay? You have the Broca area over here in the front, in the frontal cortex, in the frontal lobe, I mean. Wernicke's area in the superior temporal lobe, the auditory cortex also in the superior temporal lobe, and in the primary visual cortex. And now why is this important? Because there are certain things that these are responsible for, and you need to understand what happens if there is ischemia or if there's a lack of blood flow to these areas of the brain. So in the premotor cortex, what is it responsible for? Like we said, planning, initiation, and maintenance of muscle movement, especially complex movements. So when there's an infarct in this area of the brain, or there's ischemia, then we know that there's going to be difficulty in these things. So there's going to be difficulty of planning, initiating, and maintaining muscle movements, despite no presence of muscle weakness. So there's no weakness, but they just cannot perform the movement that they want to perform. So there's difficulty in planning, initiating, and maintaining, okay? There's no problem in actually moving on their own. Maybe the power of the muscle is perfectly fine otherwise. But then when you move to the primary motor cortex to differentiate in between these two, then we know that, okay, primary cortex is responsible for motor control. So when you don't have motor control due to ischemia or due to an infarct, same thing, then you know that there's going to be paralysis of that specific area, depending on where the infarct is in your cortex, okay? If it's more medial or more lateral. And as I showed you guys, there's a difference in what's going to be affected because you guys saw the homunculus. So motor control, this means if it's affected, there's going to be possible hemiplegia, hemiparesis or paralysis, dysarthria, so problems in language expression, but there's no problems in making speech sounds, because remember that the speech sounds also come from other nerves, and it's not necessarily like the making of the sound, it's just the problem of the motor function. You cannot move your mouth in a way to form proper words. So there's a problem in language expression, not sound formation, language expression, okay? Then you have the somatosensory cortex, which is sensory control. So if it's affected, you're going to have numbness, tingling, or partial sensory loss. Now, when we move down to Broca's and Wernicke's, so first let's go over Broca's area. This is in the frontal lobe. It's language expression, not for language expression. So when you have a problem here, or if you have an infarct that also involves Broca's area, you're going to have expressive aphasia, meaning you understand what's going on, you just cannot say it out loud. You're not able to express yourself, okay? Wernicke's area, on the other hand, is responsible for language comprehension. So you're going to have comprehensive aphasia. You don't know what these people are saying. They may understand you, but you have no idea what these people are saying. They're making up sentences that are grammatically correct, but they're nonsensical, and they have neologisms. So does anybody here know what neologisms are or what they mean? Neologisms is like the formation of new words, basically. So I remember I saw this example. It's like Pepsi plus addiction. They'll say like Pepsi addiction. Like that's an example of neologism. Okay. Now, secondary visual cortex, primary visual cortex is vision control. So you can have blindness with macular sparing. Macular sparing occurs because there's other blood flow to the visual cortex. And then in the auditory cortices, or the primary and secondary auditory cortex, this is responsible for sound localization and hearing. So especially if there's an infarct or ischemia, you're going to have difficulty in the above, in localization and analysis of complex sounds, especially if it's a secondary, primary, hearing in general, okay? If it's unilateral, it's going to be subtle difficulty in hearing. If it's bilateral, which in all honesty is more rare, you're going to have deafness, okay? Sorry. Okay. So next question. I know it's long, but sorry about the cat in the background, guys, if you guys could hear the cat. But I know the question sounds long, but it's straight to the point. Okay, so a 55-year-old man is brought to the emergency department because of sudden onset of difficulty speaking for 1 hour. So sudden onset, you know, this is most probably a vascular problem, so it's probably a stroke. He has hypertension, dyslipidemia, type 2 diabetes. Okay. Current medications, etc. On examination, the patient speaks slowly in simple sentences that consist of only one word. He seems to have difficulties understanding grammatically complex sentences and appears to be frustrated at the inability to speak fluently. He is able to follow commands. When another individual tries to enter the room, the physician asks the patient to hold the door, and he does so immediately. Based on his symptoms, which of the following labeled areas in the schematic overview, basically here on the right, of the normal brain is most likely to be affected in this patient? What do you guys think? D, Broca's area. Okay, Nasa says D. Sada, do you have another idea or another opinion? Do you think he's wrong? Broca. Okay, so let's look at it. So these are the important points to focus on. So difficult, speak slowly, simple sentences, one word, difficulty understanding grammatically complex sentences, frustrated that he is unable to speak fluently. So this is, like you guys said, correctly, good job, D, Broca's area. Okay, so remember from here, this is Broca's area in the frontal lobe here. This is Wernicke's area. So this would not be Wernicke's aphasia. It's Broca aphasia, it's not Wernicke aphasia, because he is able to understand commands. He's just not able to express himself fluently. However, in Wernicke aphasia, you are fluent, but you're nonsensical. Okay, so this is D, Broca's aphasia. Next, a 65-year-old man is brought to the emergency department by ambulance because of severe headache, nausea, vomiting that began 2 hours ago. 2 weeks ago, he was discharged from the hospital after being treated for bacterial meningitis. Okay. He appears disoriented, pulse is 55, respirations are 10, blood pressure 155/90. Fundoscopy shows bilateral swelling of the optic discs. An MRI shows that an MRI of the brain shows ventriculomegaly and scarring of a structure that is derived from the diencephalon. That's all you need to know from this question. The patient's symptoms are most likely to be caused by obstruction of which of the following parts of the ventricular system? So, you know diencephalon. So what arises from the diencephalon? A, central canal, B, cerebral aqueduct, C, lateral aperture, D, lateral ventricle, E, third ventricle, or F, fourth ventricle. Okay, good. So yes, the thalamus also comes from the diencephalon. You're absolutely correct. And both of you are correct. Nasser and Sara, E, third ventricle. Good job. So you're going to probably get a question like this where it's going to be really long. Don't let it throw you off. Just make sure that you see the important points. Okay, ventriculomegaly, derived from diencephalon. Which part of the ventricular system is obstructed? Then you know immediately. Okay, diencephalon, third ventricle. Obviously, thalamus is not a part of the literal ventricular system itself. So you know that, okay, it's the third ventricle because it's come from the diencephalon. So good job. Okay, next one. We're halfway through. It's only 10 questions. 76-year-old woman with hypertension, coronary artery disease is brought to the emergency department after sudden onset of right-sided weakness. Her pulse is 83, BP is 156/90. Neurological examination shows right-sided lower facial drooping and complete paralysis of the right upper and lower extremities. The tongue position is normal and she's able to swallow liquids without difficulty. Sensation to vibration, pain, position, and light touch is normal bilaterally. She's oriented to person, place, and time and is able to speak normally. Occlusion of which of the following vessels is the most likely cause of the patient's current symptoms? So let's look at the important points. So we know, okay, right-sided lower facial drooping, complete paralysis of the right upper and lower extremities. So is it A, ipsilateral anterior cerebral artery, B, anterior spinal artery, C, contralateral middle cerebral artery, D, ipsilateral posterior inferior cerebellar artery, or E, contralateral lenticulostriate artery? If you guys are not sure, that's perfectly fine. But just try to answer, and even if it's incorrect, it's better to get it incorrect here than on the exam. What do you guys think? Okay, that's okay. Lateral pons. Sure, okay. I understand why you're saying that, but let's talk about that for a second. If it's the lateral pons, then what else are you expecting to see? This patient is speaking normally. Their sensation to vibration, pain, position, light touch is normal. So do you still think that it's lateral pons? Remember the pons, okay, the brainstem in general. All the tracts are traveling together, right? They're traveling, and then at the medulla, they're going to cross over. So they're traveling together. So motor, sensory, all of that jazz. So in this patient who's having lower side, right-sided lower facial drooping, and complete paralysis of the right and upper lower extremities. That's the only thing that they're presenting with. Remember, it says tongue position is normal. They're able to swallow without difficulty. Sensation to vibration, pain, position, and light touch are all normal. Would you still say it's in the brainstem? Think of all the nuclei in the brainstem. Like if they're not affected, then is it still in the brainstem? It could be full body in the brainstem, like meaning not like full body, you know, like like paralysis on both sides. But I think you mean like, yes, it's hemiplegia. But hemiplegia can also happen if it's in the brainstem. But my point is over here is if it is a brainstem infarct or ischemia in a part of the brainstem, if you think about lateral pons or lateral medulla or something like that, you have to think about which cranial nerves exit from there, what they're responsible for, which nuclei are there, because those are all also going to be affected. So if this person's pica was affected, then the pica supplies which part? The lateral medulla, right? So if the lateral medulla is infarcted, then you're going to have dysarthria, difficulty swallowing, dysarthria meaning difficulty in speaking, hemiplegia, and you're going to have sensory loss as well. But over here, there's no sensory loss. There's no dysarthria. There's no difficulty in swallowing or anything like that. So we know that, okay, maybe this is not in the brainstem. Maybe it's higher up. But if we think higher up, let's just say we go to the pons, and we think about the face. The trigeminal nerve comes out of the pons, for example. There's no sensory loss in the face. So then you would probably most definitely see that in a pons infarct. There's no other signs of any pons infarct. Okay, let's go to the midbrain. Out of the midbrain, what comes out? Oculomotor trochlear nerve. There are no deficits in eye movement. They would definitely mention that here. Okay, if it's not there and it's only that specific part, if it's only hemiplegia and it's only motor, let's think about something else. It's most likely higher in the cerebrum somewhere. So where would I only see motor? And where would I see hemiplegia? Because I know, for example, if I'm thinking of the brain, the full, like all parts of the cortices, like the cortex, medially, remember what we said about the homunculus. Medially, leg and foot. When you move more laterally, then you have your upper limbs. And then when you move even more laterally, most laterally, you're going to have tongue, teeth, gums, basically all around the mouth. But this is basically all of those things. So where do all the motor fibers pass through? Where you don't have the sensory fibers necessarily. Do you guys remember? Okay. Internal capsule, yeah. Perfect. So do you have motor nerves? Did you guys learn thalamus yet? We had that post midterm. I remember when I took neuro in second year. Okay. Then don't think about the thalamus. Erase it from your memory. You don't need to know it yet. Okay, let's see. I'll show you guys the answer and I'll explain. Okay. So the answer is lenticular striate arteries. Now let's go. Let me see if I can find it here. Cannot see it here. Okay, 1 second. Your lenticular striate arteries, can you see this? Google Images. Can you guys see what I'm showing you? Yeah, okay, perfect. So look at this. This is your circle of Willis, your anterior cerebral arteries, etc. These are your middle cerebral arteries. Your middle cerebral arteries, they taught you guys about the internal capsule. They're going to be supplying the internal capsule. So basically where all the motor fibers are passing through. The thalamus is what is responsible for all the sensation and also like your special sensation, etc. And you guys are going to learn about that later. But when it's primarily just motor, and you're seeing full hemiplegia, and you're not seeing dysarthria, you're not seeing other signs of like a medullary infarct, pons infarct, or midbrain infarct, you have to think about all the things that are in there and see like, okay, is that affected? Is this affected? Is this affected? Don't overthink it. Whatever they taught you is what they will bring you. But when you see hemiplegia and you don't see sensory loss, think about the internal capsule, okay? Just think about the internal capsule. And if you see the internal capsule, you'll know, okay, lenticular striate arteries. And another way to know, okay, who would this most likely affect? Typically people with hypertension or diabetes, most likely hypertension. And the reason is because these vessels are so small that in hypertension, they can be affected. Basically, some of them can burst and it can cause an infarct, okay? Is that clear to you guys? If it's not, I can re-explain it. We can go through the other options as well to say why they're wrong.
It's clear, but I don't think we took lenticular striate. I'm just checking our slides.
Oh, really?
Yeah, just a second.
Oh, my bad. Because from what I saw, I thought it was given to you guys. Because it's definitely in the cerebral blood flow.
It was that picture that you pulled up from Google Images that was there. I'm not sure about the artery.
Okay. Okay. Either way, extra information if you guys want to know what is important for you, not necessarily for this, but definitely for your final, it might come up. Because I remember, especially for us even, and then I know for, I think the batch after, they stress on that point quite a bit. So I thought they might have stressed it with you as well. Just give me 1 second.
You're probably right then.
Okay, sorry.
Oh, okay, my bad. Yeah, it's there, and it's in.
Oh, it's there. Okay.
Yeah, it's in red.
Okay,
as
no, I
well.
was just worried because I don't want to give you guys something that you haven't taken. I don't want to
No,
add on
it's
to
fine.
any stress or anything. Okay, alhamdulillah. Okay, good. Okay, so just to quickly recap, we know it's not ipsilateral anterior cerebral artery. Why? Because it's full hemiplegia, right? If it's anterior cerebral artery, they're going to say right leg, right foot, basically, or genitalia. They're going to say that something in the bottom half of your body is affected. Then you're going to think, okay, it might be the anterior cerebral artery. Anterior spinal artery, why not? It's giving blood supply to the full anterior spinal cord. You're going to see other motor deficits and also sensory deficits. Definitely, you're going to see sensory deficits. Okay. And it might not just be, what do you call it? It might not be just unilateral, it might be bilateral if it's in the spinal cord. Next thing is middle cerebral artery. Again, if it's the middle cerebral artery, just remember, again, always think about, okay, where does this supply and what is that responsible for? So the middle cerebral artery is going to, again, lenticular striate arteries, but that's specific. And why we don't say it's the middle cerebral artery, even though those give rise to lenticular striate, is because MCA, like Nasser said in the chat, is mainly upper limb. And you're also going to see other signs, especially thinking about if it's a dominant or non-dominant hemisphere. So you're going to think if it's a dominant hemisphere, you're going to think of aphasia. You're definitely going to have aphasia, some type of aphasia. If it's a non-dominant hemisphere, you're going to have, you guys learned about it, probably briefly. Do you guys remember? They might test you on it. If you don't, it's okay. But if it's a non-dominant hemisphere, it's going to be hemi-neglect. Do you guys know what hemi-neglect is? Good, okay. Yeah. Yeah, okay. Question 6. A 78-year-old left-handed woman. So left-handed, what is that telling you? Like right off the bat. Dominant right hemisphere, like Sada said in the chat. Yeah, sorry, continue.
Yeah, I was just gonna answer.
Okay. Sorry, okay. So 78-year-old left-handed woman with hypertension and hyperlipidemia is brought to the emergency room because of sudden onset right leg weakness and urinary incontinence. What's affected? Just if you read this alone, what do you think is affected?
Primary motor contact cortex.
Sure. Okay. Good. Okay. Any idea for the artery? You don't have to say left or right, just tell me like,
Anterior cerebral.
okay, good. Yeah. Because it says leg and they're mentioning urinary incontinence, so genitalia are affected. Neurological exam shows decreased sensation over the right thigh. Muscle strength is 2 out of 5 in the right lower extremity and 4 out of 5 in the right upper extremity. Strength and sensation in the face are normal, but she has difficulty initiating sentences and she is unable to write her name. The most likely cause of this patient's condition is an occlusion to which of the following vessels? So we know her right side is affected and it's her right lower limb. And like Nasser said, the anterior cerebral artery is usually responsible for that part of the cortex because, again, remember the homunculus and remember the fibers that are responsible for motor and sensory control for the lower limb. They're more medial, and medially you have the anterior cerebral artery, right? So now the question is, if you know it's anterior cerebral artery, is it right or left? Right. Why do you say right? Okay. So that is, I guess, a little bit tricky. The main thing you want to think about here is where the leg weakness is occurring. The leg weakness and the urinary incontinence. So the leg weakness is on the right side. So that means if you're thinking about the cerebrum, remember that the fibers cross over. So it is going to be contralateral. It's usually contralateral hemiparesis and sensory loss. So it's going to be the left. So even though she's left-handed, and this is something they probably mentioned to you, whoever taught you the cerebrum, but left-handed people typically also are left dominant, which is so confusing. I know it's kind of confusing. But majority of them are still left dominant. But so if you see that, don't necessarily think like, okay, just because this is the dominant hemisphere and she can't do this now, for example, hemi-neglect only happens in the non-dominant hemisphere. Hemi-neglect, yes, only happens in the non-dominant hemisphere, but then that will be very clear in the question stem and you'll know, okay? But, and they won't try to trick you. They'll say like, okay, this patient has hemi-neglect, basically they'll describe hemi-neglect and they'll say, for example, this patient is right-handed, then you'll know, okay, it's the right hemisphere that's affected, it's the non-dominant hemisphere. And this patient, if they say if the only information they give you is it's a left-handed woman and she has hemi-neglect, then you'll think, okay, left, the right is dominant, maybe the non-dominant is the left hemisphere. That's not a wrong answer, okay? So it does throw you off, yes, this will definitely throw you off. But when you see something like this, think about, okay, where is the hemiparesis? Where is the sensory loss? And you know that it's one part, so it's most likely in the cerebrum because it's more concentrated in terms of like the symptoms. When you see that, think about, number one, it's the cerebrum, and think about, okay, if it's on this side of the body, contralateral, because remember in the medulla, what happens? Your fibers cross over, okay? And then for sensory, they'll cross over again in the spinal cord, okay? Okay, good. So it's the left anterior cerebral artery.
But what about the difficulty initiating sentences? Isn't that Broca's?
Difficulty initiating sentences.
Because it threw me off. It's different.
That does throw you off. Difficulty initiating sentences. I think this would be, that is very confusing because she is left-handed and it's in the left hemisphere. I think what they want you to focus on in this question, because by the way, when I was answering this question, it is one of the harder questions on AMBOSS.
Mhm.
they want you to focus on the fact that where's the deficit in terms of motor, like in her motor, like where's the motor deficit in her body, if it's on the right or left, and if it's on the right, then do you understand that you're supposed to answer, okay, it's contralateral, so it's left. I think that's the main thing they want you to see. But well, listen, that is confusing. I will read about it and then I will get back to you after. I'll put it in the notes in the bottom of the slide, and then when I share it with you, then it'll be there, okay?
All right, perfect. Thank you.
No problem. That is confusing though. I would be thrown off as well.
Yeah.
The trick usually in answering these questions is to not read too much into everything they're saying. You have to just pick out, and it comes with practice, but you're going to pick out the thing you're like, okay, right lower extremity, normal right upper extremity, etc. Urinary incontinence, okay. Anterior cerebral, okay, it's on the right side, so the left one is affected. But that is confusing, so I will get back to you on that. Okay. Question 7 is slightly maybe a little bit more tricky, only because you're looking at the brain as if you're looking at it from the front and not from the side normally, like we usually do in other questions. But a 62-year-old man with hypertension and atrial fibrillation is brought to the emergency department because of sudden onset visual changes. He stopped taking all of his medications 2 months ago. Blood pressure is 170/90, pulse is 108. He is alert, oriented to person, but does not follow commands. His speech is fluent with normal cadence, but he uses frequent non-existent words, and the content of his speech is nonsensical. He appears unaware of his speech impairment. He is unable to read a text out loud. Peripheral vision is diminished in the right upper visual fields bilaterally. This patient's presentation is most consistent with injury to which of the following labeled areas? And can you guys see that properly? Or would you like me to zoom
Like,
in?
I know it's Wernicke's, but I don't know where Wernicke's would be.
Yeah,
Okay.
exactly.
Good start. No, that's a good start.
Like
Great. So
C, I
perfect. You
think.
know it's Wernicke. You said C?
Yeah, because Wernicke's was a little bit like on the posterior aspect of the
Yeah, it's
brain.
on the temporal lobe.
Okay. I get why you're thinking C because it's posterior, but just remember this is all at one cut. So think like medial lateral. So you know, okay, you're right about Wernicke's, definitely. But now it's about, okay, where's Wernicke's on here? So I'll
Okay,
give you a hint.
so
Obviously.
D or
It's not
E, I think.
D or E. Okay. Which one would you say it is?
Oh, E, because it's frontal lobe. Wernicke's one's on the frontal lobe.
So close.
Or sorry, temporal lobe, sorry.
Yes,
Wernicke's is on the
perfect. 2
temporal
minutes.
lobe.
Perfect. It is tricky. It's really weird to look at it from this angle. So, okay. Good job. So we know, okay, content of the speech is nonsensical. So that you're perfectly, like, you're on point, correct? It is Wernicke aphasia, and that is E over here. It is in the temporal lobe. So this would be basically over here on the temporal lobe. Well, over here, but basically they want you to know over here. I know this is honestly off-putting. I don't like this question now that I think about it when I look at this, because Wernicke's area is more here, a little bit more posterior, like you said, right? And then this would be where Broca's is. So technically D, like in the questions I remember, D, the option was like representing Broca's area, but Broca's area is more anterior. What they want you to know from this is more of the anatomy. So they just want you to know, like you said, Wernicke's, okay, you're going to think temporal lobe, so it's going to be the one on the temporal lobe. D, Broca's is in the frontal lobe, so you're going to answer that for D. That's Broca's, and etc. Do you get what I mean?
Yes.
That's the main concept you have to take from here. Wernicke's, temporal, superior temporal lobe. Broca's is the, I guess, lateral aspect of the frontal lobe. Okay, that's all they want you to know. So over here, you would see Broca's area around here, Wernicke's here, and then you'll have your conduction aphasia occurs when the connection between these two is cut off. Okay, now, wait, just give me 1 second. Okay. This cannot be happening. Okay, A 71-year-old man with hypertension and hyperlipidemia is brought to the emergency department after sudden onset of slurred speech 1 hour ago. Physical examination shows drooling and hypernasal speech. His face is symmetric and strength is 5 out of 5 in all extremities. This patient's presentation is most consistent with injury to which of the following labeled areas of the primary motor cortex? A, B, C, D, or E? I know you guys might have seen it, but I want you to go off this. So sudden onset of slurred speech, drooling, hypernasal speech.
You said that laterally is like the tongue and everything, so I want to say A or B.
Okay, good. Nasser, do you have any other opinion?
No, but my mind went off to Broca's areas because of the slurred speech. But then I
Okay.
don't know, I was confused between.
No, it's okay for that confusion. So basically, one thing that is important for you to know, and it's okay you're having that confusion, slurred speech does not mean Broca. Slurred speech is solely motor.
Okay.
And Broca's is not motor, right? It's about expression. So they can understand commands, they're just not able to literally form words. That's all. And they're aware like, oh, I can't form words. What's happening? In slurred speech, which is solely motor, they're able to form words. They want to form them, like they're able to form them in their head and then say them. But because their tongue is affected, because their motor neurons are affected, they're not able to actually say that clearly. That's all. It's just it's solely motor.
Okay.
Do you understand?
Yeah.
Okay, perfect.
So it's A because of the homunculus, right?
Yeah, good job. So you guys are right, A or B. It's a little bit confusing, I know, because they're both lateral, but safer to say if it's solely just like a problem with speech, motor, if it's a motor problem with speech, if they're drooling, if it's hypernasal speech, it's safest to say it's the most lateral aspect of the cortex. Definitely go for that answer. Because over here, remember that you have hands, fingers. Over here around C, you're going to have, and D, you're going to have your upper limbs, and then around E, you're going to have your, again, legs, genitalia, feet, okay? So lower limbs, upper limbs, face, mouth, teeth, gums, etc. Okay?
Do you, if your exam, they like put up images of the brain, like, or were they more like questions?
Can you ask it again? Because you cut off a little bit. Sorry.
Do you remember if in your exam they asked you questions about like where it was like physically on the brain? Pulled up pictures like this?
From what I remember, yes, I think we did get 1 or 2 questions like that, but a lot of them were also, and you'll see this like sometimes in your practice questions. What's the diagnosis? This person is unable to, they're able to speak fluently, but they're saying nonsensical stuff. Which area is affected? Or what is this called? Is it conduction aphasia, expressive aphasia, etc.? You know, that's usually sometimes you'll get the question like that, or you can get it in like a picture. I remember we got one where it was like, which of the labeled areas of the brain is affected, etc. I remember if it was not on our midterm, it was definitely on our final, but I do definitely remember getting a question like that. So 100%. That's why I'm showing this to you guys, because if not, it might be on your midterm, most definitely. If it is not on your midterm, if it is not in your MCQs, which I highly doubt will be the case, but if it is not in your MCQs, it will 100% be in your OSPI, 100%. So it's good practice for you now, and then for you to then take on until then. All right? Okay. So this was just like a reminder of the homunculus. So remember, most laterally, you have the tongue, chin, mouth, so vocalization, salivation, mastication, chewing. Mastication is chewing. And you go into a lot more about this in HNS in your next block as well. And then over here, laterally, but slightly more medially, I guess, you'll have the rest of the face, then you'll have your upper limb, specifically more your hand. And then most medially, you're going to have your leg, feet, and then they didn't show here, but also your genitalia. Okay. So second to last question. This is kind of how I remember we got, I think, 2 or 3 questions like this in our midterm. No joke, like the one that you're about to read now. But a 73-year-old man is brought to the emergency department 30 minutes after the sudden onset of right-sided body weakness. His wife reports that he does not seem to understand simple questions. He has type 2 diabetes, has smoked 1 pack of cigarettes daily for 45 years. The patient speaks fluently, but he answers questions with nonsensical phrases and cannot repeat single words. Which of the following is the most likely diagnosis? A, Broca, B, conduction, C, transcortical motor aphasia, D, global aphasia, E, Wernicke's aphasia, F, transcortical sensory aphasia, or G, anomic aphasia.
Is it Wernicke's?
So nonsensical, cannot repeat single words. Correct. It is Wernicke's. You both are correct. E, Wernicke aphasia. And then now I wanted to ask you before I show you the next slide. How do you know the difference between Wernicke's versus conduction aphasia? Or conduction versus Broca's aphasia? What is the difference between the three?
I think Wernicke's was the comprehensive, so like understanding aphasia, and then the Broca's was just like speaking, like expressing what you're saying, expressing your language aphasia.
And
Perfect.
conduction is both of them. So the patient would be mute,
Good.
isn't he?
So I think, yeah, wait, I'll show you guys the next slide. Come on. Okay. This image doesn't look as clear. I don't know why at this size, but it was more clear when I put it on. But over here, you can see this is Broca's is more specifically responsible for the fluency. Wernicke's area for the comprehension, and conduction aphasia, which is when the arcuate fasciculus, that's responsible for repetition. So over here, just look at the first three, because you guys can look at this later in your own time. I don't know if they fully taught you this in detail. They probably definitely taught you global aphasia. But Broca's, Wernicke's, conduction, these are the three main things that you need to know. And these are also the three main things they ask us about in 5th year neuro as well. It's the things that you carry on. So Broca's, you have no fluency, but you do have comprehension and you have a problem in repetition. Okay, because it's about fluency, it's about expression. So you can't express, so you obviously you can't repeat. Wernicke's, you're fluent, but you can't repeat because you're not comprehending, because the comprehension is not there, right? So just remember these three things: fluency, comprehension, repetition. So Broca's, you do have fluency. Sorry, Broca's, you don't have fluency. You do have comprehension and you don't have repetition. Okay, because it's about fluency, it's about the literal expression. If you cannot express, you cannot repeat. You also need comprehension for repetition, right? You need comprehension for repetition. So in Wernicke's, you are fluent. However, because you cannot comprehend, you cannot repeat. Okay, and in conduction, your fluency and comprehension is fine, but because your arcuate fasciculus is affected, you're unable to repeat. So that's your main thing that you're going to find. So maybe they might give you an example of a patient who, let's just say they're able, when you ask them to open the door, they're able to open the door immediately. They can speak fluently and it makes sense. However, they cannot repeat. Conduction aphasia. Wernicke's, they're fluent, but we don't know what they're saying. It does not make any sense. They don't realize that it doesn't make any sense. They're just speaking as if they understand what they're saying. Wernicke's aphasia, they're unable to repeat. Broca's aphasia, the patient is obviously frustrated. They're unable to speak. They can completely understand you. They're just not able to express themselves. That's how you know it's Broca's. So the main thing that will tell you conduction aphasia, apart from Wernicke's, is the fact there's comprehension, but they're just still not able to repeat. Okay. And the difference in between conduction and Broca's is they're fluent and comprehensive, but they cannot repeat, but they are fluent. So you don't have fluency in Broca's. You don't have comprehension in Wernicke's. You have both of those in conduction, you just don't have the repetition. Is that clear?
Yes.
Perfect. Okay. Last one. Which of the following will most likely manifest in this patient if this part of the brain is affected? And what is this part of the brain? We spoke about it earlier.
The internal capsule.
Perfect. So what will you see over here? So this is the left side. Will you see A, weakness of the right leg, B, hemi-neglect of the right side, C, hemibolismus of the left side, D, paralysis of the left face, E, loss of sensation of the left arm, or F, hemianopia of the right visual field?
B.
A.
Sara, why do you say B?
Internal capsule. So I'm just thinking all of the motor things that could go through there.
In hemi-neglect, do you have motor problems? Like, is that the main thing in hemi-neglect?
Honestly, I forgot what hemi-neglect was.
It's okay. So hemi-neglect is literally, like in its name, neglecting literally half. So
Oh, okay, no, that's like the clock thing and everything. No.
exactly. So basically, when you ask them to draw a clock, they're going to stop at half. So they can do 1 to 12, but they're not going to do 1 to 12 like this. They're going to do 1 to 12 like this. They can't see half, so they're not going to have. Sometimes there's even cases where let's say like, oh, the patient only shaves the right side of his face, for example, or like the left side of his face, or he completely neglects the left side of his face when he's shaving. Then you know, okay, this is hemi-neglect. So they don't have a problem with the motor, but they just have a problem in literally acknowledging half of what they can see, half of their presence. So Nasser said A. Why did you say A? Why weakness of the right leg? Why not another option?
Because we just said that the motor fibers pass through the internal capsule, since this
Good.
is on the left side, so, and it will cross in the medulla. So
Mhm.
the manifestations would appear in the right side.
Perfect. So yes, you're correct. It is weakness of the right leg. So internal capsule, remember the motor fibers, and they're at different parts of the internal capsule. So I honestly, I genuinely forgot exactly, but depending on which part of the internal capsule, it's going to be motor neurons for the upper limb, hand, lower limb, etc. So when you have an infarct in a certain part of the internal capsule only, you might, and this is a more challenging question that I don't think you're going to get a question like this specifically. You might get a question in this style where it's going to be very obvious, like, okay, they want you to say like a motor deficit. And there's not more than one motor deficit here that is correct for this question, right? But just know that if it's a specific part of the internal capsule, sometimes you won't have full hemiplegia or hemiparesis. It might just be paralysis of the lower limb. It might just be paralysis of the upper limb or something like that because it's in the internal capsule. But that's a more challenging question. So you're absolutely correct. You're going to see weakness of the right leg because this is on the left side. And then, like you said, the motor fibers will cross over with in the medulla. So you're going to have contralateral weakness or hemiplegia or hemiparesis. Good job. So it's weakness of the right leg. All right, that's pretty much all I have for you guys here. So just remind me again, the things you said. Sarah said Gerson syndrome earlier. And was there anything else that I didn't touch upon that you know is going to come? And I'm really sorry, by the way, that I didn't include it.
I just knew the 3 clinical things. The conduction aphasia that you did, I think, and Gertzmann, and the contralateral hemi-neglect. And yeah.
Okay. So I touched upon that, but I'll definitely add them in the notes before I send them to you guys, okay? So let me just write that down somewhere else.
Did you make that table in the very beginning? The little brain thing? That was really nice.
Wait, which one? I want to take credit, but I probably didn't. Wait, which thing?
Go more down. Yeah, I think the one after, yeah, this one.
I got this off of Amboss, but these things, like the green and red, I added them myself.
Yeah, the green and red are really good. They really help.
Thank you. I'm happy they helped. That's all I care about. I'm glad they helped. All right. So do you guys have any questions for me before you go?
Thank you so much.
Anytime. Thank you guys for staying and participating. I appreciate it. I know you guys had a really long day, probably.
No, this was beneficial. I wanted to go over it anyways.
Thank you. Okay. All right. If you guys have any questions, I'm going to share it with you. It has my email, but I'll write it in the chat really quickly. and my WhatsApp. Please do not hesitate to reach out to ask any questions at all about anything. I usually reply pretty quickly, and it's never too much. Like, don't worry about that if you feel like, oh, I'm asking too many questions. All right. So best of luck, and you guys, inshallah, will do great. Allah yuwaffiqkum. You have nothing to worry about.
Inshallah. Thank you so much for your time.
No problem. Thank you, guys.
Thank you.